Susan, can you hear me?
Yeah, I can hear you.
I think we're live.
So this is track 3 of the Global Alliance for Genomics and Health's plenary meeting. And if we could move to and my name is Susan Fairley. And if we could move to the next slide, please, thank you. So I'd like to start by pointing out that translations are available for this session. The link listed on this slide is where you can find those. And we have translations available in Japanese, Spanish, German, and French. And there's also an English language captioning service available. Moving to the next slide, please. So I'd like to welcome everybody to this session and indeed to the meeting overall. It is our absolute pleasure to have you join us for this. And then moving to the next slide, please. We are delighted to see that we have continued to see growth in terms of the number of countries represented at this meeting. Having participation from so many places really makes all the difference to GA4GH. And it is wonderful to see the levels of engagement continuing to grow year on year. Some of this no doubt due to the switch to a virtual meeting in the last couple of years, but we're really, really pleased to have so many people from so many different parts of the world joining this meeting. And if you could move to the next slide, please. We also want to recognise that obviously now and in recent times, it is not business as usual. And we would like to thank everybody who's both finding time to attend this meeting and also who contributes to our work, who participates in standards development and implementation, for finding time to do this while you've been taking on new responsibilities related to COVID, taking on additional work, those of you in clinical settings, and adjusting to just a different way of working for everybody. We really appreciate the levels of support that people in GA4GH have shown to each other and your ongoing contributions to this work in very difficult circumstances. And moving to the next slide, please. So if you want to get in touch for any technical support during this meeting, there are a number of options open to you. We have a technical support from the platform providers for this meeting, CVent, and you can contact at cvent-support@ga4gh.org. If you have questions about GA4GH, we have another couple of channels that you can use. We have a Slack set up, you can ask questions on the general channel there. And in addition to that, you can also contact the GA4GH operations team at operations@ga4gh.org. And moving to the next slide, please. So if you want to reach out and talk to other attendees at this meeting, again, the Slack instance that I mentioned is a great way to get in touch with people. The general channel, you're completely welcome to post there, whether it's comments or questions about the talk. It's also a really great place to join if you want to be able to continue conversations after the meeting. So great to post there during the sessions, but also possible to go ahead and continue those conversations down the line or pick things up, in a week or two. So really encourage you to take a look at that. And also there's a bunch of other channels on there dedicated to specific standards. So if you have a specific topic of interest, you may find something on Slack that is going to catch your eye. And moving to the next slide, please. For the course of the meeting, most things are gathered in the attendee hub. The URL here is where you can find that. So if you log into that, you should have received an email or registration. You can log in there and that will list the full schedule and links to the poster sessions and so on. And the next slide, please. In terms of reaching out to the wider community at the meeting, again, we have the Slack instance that I've mentioned. If you want to use Twitter, you're very welcome to tweet. We have the tags associated with the meeting listed here on the slide, 9th Plenary and GA4GH community. And in addition to that, we're also using Spatial. So there's a lounge space where you can go into Spatial and talk to other people there. And moving to the next slide, please. So one of the things that we're doing at this meeting is using Slido for questions. And we're going to give you a chance to test this out just now. So if you want to open up a new window or tab in your browser, and you can enter in Slido, sli.do. Once you've got that up, it should give you a prompt where you can enter a code, and that would be GA4GH for our meeting. And then once you've done that, you can then post questions. And you can also upvote questions from other people if somebody else has already asked the question that you're interested in. So we're going to test that out just now, and you're going to get to ask some test questions of me. So I think if we move to the next slide, we will hopefully start to see any questions that anybody wants to ask. So where in Scotland am I from? Excellent work placing the accent. I'm from Aberdeen. I don't know if we have any other questions. I'm going to give it a second and then we're going to move on. Okay, I'm going to take that as a successful test, but we will move on to the next slide, please. Oh, and GA4GH so far is very good. Thank you very much indeed. I've been as acting as the Chief Standards Officer for 6 months, and it's been an absolute pleasure. that one I don't know the answer to. So if we could move on to the next slide, please. Okay, so we had a great first day for this meeting yesterday. We've already had 2 tracks that have presented. If you didn't manage to catch those live, this is not a problem. There are now links up to recordings of these on the Attendee Hub. So if you go to the Schedule tab, there's then an on-demand option, which will link through to these 2 recordings. Track 1 included our wonderful keynote presentation from Harold Varnes, talking about genomics and the World Health Organization's perspective on that. We also had updates on some current initiatives in GA4GH, some work from our EDI advisory group, presentations on a bunch of different work going on in the different standards, and also presentations on the Federated Analysis Systems project, which seeks to pull together different standards, and also our starter kit implementation to help people getting up and running. We then also had a brilliant track 2 that included a presentation on the Genomics Health Implementation Forum from Catherine, and then moved on to a set of really amazing talks about real-world implementations, where people were talking about how they were deploying and using and putting into use GA4GH standards in their own environments. And that included talks from Australian Genomics and groups in Singapore and Japan, and some really incredible work going on there. We were then also incredibly fortunate to have a really great session on engaging with underrepresented communities. So this included presentations from CoVarNet, from the Human Pangenome Reference Consortium, the Australian Centre for Indigenous Genomics, and all of us, and also a really, really interesting panel discussion at the end of that. So if you weren't able to catch those, I'd really strongly recommend trying to check out those recordings. They're really, really interesting, really good. So moving to the next slide, please. So today we're moving on to talk about responsible data. Responsible data sharing is really at the heart of GA4GH. It goes to our 2 foundational work streams, looking at ethics and security. And if you could move to the next slide, please. So our schedule for this session for track 3 is going to kick off with a panel talking about responsible data. We have presentations looking at privacy preserving federated analytics, looking at responsible data sharing, ethical, legal and governance considerations around this, and responsible return of results. And that's going to finish up with a panel discussion. We then have a short break, and then we're going to pick up again on a similar theme to part of yesterday's session, looking at real world implementations. And today we're going to be hearing presentations from the Beyond 1 Million Genomes project, from NIH's cloud interoperability work, H3 Africa, and also looking at Beacon as a presentation from the Centre for Genomic Regulation in Barcelona. So moving on to the next slide, please. So we have some expectations for conduct during this meeting. We expect all participants to be respectful, and also we ask people to please be transparent about any potential conflicts of interest that you may have. The following behaviours that are listed here will not be tolerated, so discrimination, harassment, sexual harassment, disrespectful behaviours or violence are not acceptable. And moving to the next slide, please. And finally, I would like to just thank the organising committee who have put this together. Their names are listed here. They have done an incredible job of work. Anyone who has ever participated in organising one of these meetings will know full well the amount of effort that goes into this. So we have had a wonderful meeting so far. I'm sure that day 2 is going to be every bit as good, and we owe everybody listed on this slide a huge thank you for their efforts to put together such a wonderful meeting. So with that, if we could move to the next slide, please. And I'm going to hand over now to Alice, who is, I think, going to be chairing the first session and our first presentation in this session. And I hope you're going to thoroughly enjoy this track. Thank you.
Thank you very much, Susan. Hopefully everyone can hear me. And I'll say hello first. I'm Alice Mann. I am a workstream manager for GA4GH. Like Susan, I'm relatively new. I've been GA4GH for 4 months now, and I manage 3 of the GA4GH workstreams, one of them data security, as well as discovery and data use and researcher identities. As Susan said, I'm chairing today's session on responsible data, and I'm delighted to welcome our 4 speakers today. We'll hear from each of our speakers in turn, and then at the end we have a decent amount of time for discussion and Q&A afterwards. And of course you can submit your questions via Slido. So first, I would like to welcome JP Houbeau, who is a full professor at EPFL, the head of the Laboratory for Data Security. He is the academic director for the Centre for Digital Trust and leads the Data Protection in Personalised Health project funded by the ETH Council, and of course is co-chair of the Data Security Workstream for GA4GH. So today he's going to talk to us about truly privacy-preserving federated analytics for precision medicine with multi-party homomorphic encryption. So if I can pass over to JP, he can.
Thank you so much. Thanks for the introduction. Can you hear me well? Yes, very good. Okay, so good afternoon, good morning, dear colleagues. It's a pleasure to be here. So this talk will indeed focus on the truly privacy-preserving federated analytics for personalized medicine. And this is work that has been carried out actually with a number of co-workers, both on the medical side and on the computer science side. And I do acknowledge their fantastic contributions. Next slide, please. So there exists a number of solutions for distributed learning. It can be either fully centralized, or it can be meta-analysis, it can be decentralized, it can be differential privacy decentralized. It can be cryptographic decentralized. All of these, we have really looked into all the details and the features of these solutions, and they come with drawbacks that brought us back to the blackboard and say, try to find, let's say, a better solution. So please click. Next slide. Click, voila. Because many of them have data leakage. Click, please, again. So differential privacy deliberately needs to introduce noise in some way, which is undesirable. Click again. Voila. Those existing solutions that rely on cryptographic techniques suffer of a very limited number of parties. Click. And so we introduce FARM. So we'll see on the next slide what it is about. So FARM is, we believe, the holy grail for secure federated analytics of health data. And this is actually a paper that will soon appear in Nature Communications, joint work with the MIT, the Broad Institute, and the Lausanne University Hospital. Click. Voila. So what we do here is, what we've shown is that we have taken existing studies. Here is one of the examples that is shown here is a GWAS that was published in Nature Genetics actually 2 years ago. And what we've shown is that we can reproduce, so the study that was published was actually centralized with all the data in clear text. We can do the same. We chunk artificially, let's say, this data set in, for example, 3 parts, keep the data separated, and show that it is possible to obtain the same results with the same level of precision without transferring the data. So the data remain in their silos where they are. And this shows that, and this, I think, is exactly what GA4GH is trying to achieve. and will be actually a fundamental building block in order to move forward. We also show that this can be achieved with a runtime that is really very, very modest. What is shown on this example is actually survival curves with a Kaplan-Meier statistic computation. On the next slide, let me move please to the next slide. We show the similar kind of result, in this case with for GWAS. And as you can see on small a, this is the original approach. On small b is actually what it shows is that the outcome, the Manhattan, if you wish, plot is exactly the same if the work is if the computations are carried out on decentralized data under encryption. Whereas what C shows here is that if this is done independently, or let's say with trying to make the computations at each place and then in some way trying to compute averages and so on, this leads essentially to nowhere. Let's move to the next slide. So what is shown here is the how much that takes. Of course, so GWAS, as you know, is quite a demanding computation. So the runtime is in the order of hundreds or thousands of minutes still. But there's still substantial improvements that are possible by making use of GPUs as opposed to CPUs. So this can bring a 10x improvement. And in any case, it's much, much faster than having to have the lawyers on each side to agree on how, let's say, on the legal protections that have to be set up for a given collaboration. So this would essentially streamline the whole process of collaboration on specific, let's say, on data sets. For example, the scale of the GA4GH. Next slide, please. So this is built on a certain number of building blocks. One is homomorphic encryption. So in a nutshell, what homomorphic encryption does is to provide the ability to make computations on data while the data are encrypted. So I'll spare you the details, but this is essentially the key message. It is the ability to make computations on data that are encrypted. On the next, please, next slide. The next building block is about secure multi-party computation, which is the ability to make computations on data sets that are distributed in different places without moving these data. And then the third building block, next slide, please, is the combination of the two. So if we move to the next slide. Next slide. Voila, is multi-party homomorphic encryption. It is the combination of those two, and this is actually the trick that makes the whole thing, let's say, reaching the level of performance that is needed, is essentially the ability to encrypt under a public collective key that is known by all parties, but the corresponding secret key, the key for decryption, is actually distributed among the whole parties, which means that the more parties are, let's say, the more partners, institutions are in the federation, the more, even the higher the robustness of the whole scheme becomes. If we move to the next slide, please. So next, actually, building block is federated learning, which is the ability to have local iteration that refine a given an ML model little by little, and then have a global model update that leverages on the partial results. Next slide, please. Well, let's say the outcome of this, let's say the fact that we have shown that this can be applied in various areas, so of course the medical sector, but also in other places such as cybersecurity or insurance, has generated so much interest that we have decided to launch a startup called Turing Insight. So I'm declaration of conflict. So I'm one of the co-founders, and this is actually the way for us to be able to provide something that is sustainable in the long run. Because I'm with an academic lab that is not supposed to provide, let's say, commercial solutions, but this is something that is actually provides a let's say long-term perspective for all these let's say capabilities, and that will provide either open source code or at least open source APIs for the most let's say advanced computations. Next slide, please. Well, so of this we have also derived a system that we are deploying currently in Swiss. We have already started deploying Swiss hospitals. Medco that actually is, if we move to the next slide, so it's based on the techniques that I've mentioned. And what it does is first it supports exploration, cohort exploration. So for example, how many individuals with a given set of features are available in the federation. And then if we move to the next slide, the second feature is next slide, please, is actually the Medco analysis. So the ability to make computations, including the example we have seen with Kaplan-Meier or linear logistic regression or neural networks on the cohort that has been identified. Next slide, please. So this is an example of application in the Swiss landscape. So first question, how many adult cancer patients consenting, blah, 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 are there as the exploration? And then question 2 is, among these patients, what is the overall survival for patients with and without mutation and so on? Next slide, please. We've also started to experiment installation at the international level. So we have currently one installation in Houston, one in the Netherlands, and one in Italy. Next slide, please. And there is a live demo that you may want to check whenever you wish at medco.epfl.ch/demo. Next slide. Now, there are scalability results that show that essentially the, let's say, layer of protection that we are bringing, in most cases, essentially brings relatively little overhead. Because this is, we have paired actually this with I2B2, for those of you who know this tool. And actually much of the computing time goes to the database operations as opposed to the encryption decryption. Next slide, please. Now we've worked also with legal scholars and ethicists to check GDPR legal compliance. And so we have published a paper that has appeared in JMIR, the title of which and the link to which are provided on this slide. So this is really joint work between, let's say, bioinformaticians, ethicists, law scholars, and computer scientists. Next slide, please. We also went through something that is called a DPIA, so Data Protection Impact Assessment. It's got a pretty thick document that shows essentially what changes when introducing such solutions into existing systems. And so you can see on the left-hand side the situation as it was before, and a situation as it is after the introduction of this solution. And so, as you can guess, red is bad and green is good based on a certain number of criteria. I'll spare you the details, but I think you get the gist of the whole thing by looking quickly at the slide. Next slide, please. Then we got also the feedback from the Swiss authorities on this document that essentially says that as no entity has a full decryption key, it seems indeed unlikely that the attacker could decrypt and abuse the stolen data. So we have received essentially kind of a vetting from these authorities, and then we move on with now a larger scale deployment of this tool set. Next slide, please. Well, then we also studied the positioning of what we have done with respect to similar distributed platforms. So those that are the most known to those on this call are probably the Shrine and the Data Shield from sales colleagues from UK, and then Vantage 6 from the Netherlands and Germany, based on a certain number of criteria that are organized in usability, privacy, security, and functionality. And Medco being a more recent tool, of course, checks actually all the boxes. Next slide, please. Voilà. So now we have also devoted some thoughts to what this would like in the case there is a willingness to introduce this in the GA4GH ecosystem. And I put really speculative on the title because there is no decision whatsoever that has been made, or just, let's say, ongoing discussion with the Elixir cloud and the AII driver project. So a medium-term possible goal would be to use tests to call the Medco APIs, and then the more longer term would be to turn Medco into a GA4GH tool involved. And please, let's move to the next slide. So the medium-term goal would be that is depicted actually on this slide. I guess it's relatively straightforward. And the next slide shows how it would operate, what can be done in the long term, and the relationship with, let's say, the tool registry service, the workflow execution service, and the data repository service, where essentially Medco would be the engine that federates the different, let's say, repositories. Next slide, please. Well, our conclusion, so what we have shown that essentially, I think we have solved the problem of federated analytics for medical data. The solution consists in relying on multi-party homomorphic encryption. So it is, we let's say, leverage on the fact that it is possible to share without sharing. It is possible to perform computations without seeing the data. And this is based on decades, let's say, of research in computer science that is based on, let's say, mathematically proven properties. So what it provides is a protection of the partial aggregates, which is a feature that is missing in all other solutions. So we have seen the scalability. We have also shown that it works on real-size medical data sets. And we believe this will be a game changer for ML on medical data. And we believe GA4GH to be really one of the probably the most promising adopters of these techniques. I've mentioned Medco, and you may want to check the website dpia.ch, where you also find all the papers we have published on this topic. Thank you for your attention.
Great, thank you very much, JP, for that fascinating talk. Thank you to those who've already submitted questions. We're going to hold them till the end and go on to our next speaker, but please do keep submitting if you have any now. So next, I'd like to welcome Jonathan Darcy to talk to us today. Jonathan has over 25 years experience using large-scale computing to advance science. He currently works at Toronto's Hospital for Sick Children on the CanDIG project, helping to build a federated platform for national scale analysis of locally controlled private genomics data to connect Canada's health genomics data. And he's going to speak to us today about CanDIG and responsible data. So I will hand over to you, Jonathan. Thank you.
Terrific. Thanks very much. Next slide, please. Thanks. So CanDIG is building a platform, an infrastructure for supporting data sharing. And we've been learning from the GA4GH really since even before our beginning. Our initial design and planning was strongly shaped by discussions going on in the GA4GH community. And some of our code actually came directly from the GA4GH community. And this has been true in matters technical. And on the next slide, please. Thanks. From policy point of view as well. So one of the ways this has played out, next slide, please, has been around early discussions about what eventually became the foundational principles for responsible sharing of genomic and health-related data coming from the GA4GH. Respecting individuals, families, and communities, advancing research and scientific knowledge, promoting health, well-being, and the fair distribution of benefits, and fostering trust, integrity, and reciprocity. So these are fundamental principles, and there's some tension between some of these principles, and the right way to resolve some of these tensions is really going to depend on the context in which you're trying to build a technical solution. Next slide, please. And so today I want to tell you a little bit about our context and the decisions we've made and our interpretation of these principles in our federation design first and then implementation. Next slide, please. So our context is Canada, and Canada is confederation with healthcare and by extension health data, the jurisdiction of provinces. So national projects require some way of collaborating across different regulatory statutory requirements. There's multiple ways of doing that, but we wanted to help make it a little easier. Next slide, please. So when designing our federation, we wanted to support the respect for individuals, families, and communities by ensuring local control over data. Make sure that the clinicians, custodians closest to the participants were accountable for final data decisions. Next slide, please. Thanks. We wanted to support the advance of research and scientific knowledge by making it easier to maintain and begin national projects, by making it easier for data custodians to be able to, in good conscience, make their data available for discovery. And we focused really initially on data discovery and exploration, these research first mile barriers. That's where we felt we could do the most good the most quickly. Next slide, please. For promoting health, well-being, and fair distribution of benefits, again, we wanted to empower local custodians and empower data programs to make it, to allow them to share and make their data discoverable in a way they're comfortable with. Next slide, please. And finally, fostering trust, integrity, and reciprocity. We really wanted to build a peer-to-peer federation, local authorization control, local infrastructure for authentication using trusted local data infrastructure, and make sure that our sites, our platform, and our data programs are all collaborators in governance. Next slide, please. And that became CANDIG, the Canadian Distributed Infrastructure for Genomics. From those foundations, it took a little while, but we developed very clear roles and responsibilities between the platform, the sites, and the data programs. And this division of responsibilities was essential for responsible data handling because we had to know who ultimately was responsible for what. Next slide, please. So we're a distributed infrastructure. There's no central hard infrastructure of any sort. The infrastructure there is coordination around policy, process, software development, and governance. Next slide, please. Thanks. So as mentioned, authentication, we use federated recognition of distributed local identities. Individual institutions are responsible for identity management. Next slide, please. Thanks. And for authorization, as mentioned, local control. It's the data hosting sites are the ones that are best able to make authorization decisions and most responsible for the consequences of those decisions. But they need platform level data to make these decisions. They may rely on claims from a user's home institution about the nature of that user. They may require information about local or platform level claims like DAC portals. And we're moving to using GA4GH passport visas to communicate those claims, that authorization related information to the sites. Next slide, please. And our trust model right now is very strong trust between sites. We're in the business of helping participating hospitals and researchers connect to support their existing data sharing projects. And we have CANDIG team members at each site developing and operating the stack. Next slide, please. So that was our federation design. Then the question becomes, how do these principles inform our implementation? And this has been on our mind quite a bit lately because we're just about finally to put into production a new version of our platform. And so we've been thinking about this quite a bit lately. Next slide, please. So we started off really all about genomics, but health data research marches onwards, and there's increasingly rich data types that are different enough they don't make sense to keep in the same data store or serve with the same data services. So we've needed to ensure data access policies are being decided uniformly across a growing range of services. And we're implementing that with a central policy decision point that evaluates each request against a declarative domain-specific language that's relatively easy to read. So that gives us one place to maintain policies and audit the decisions against those policies. Next slide, please. We want to make it as easy as possible to have secure deployments at each site for this new version. So that means a repeatable, secure stack where security relevant decisions are made in a sensible way. And it makes it as easy as possible for new sites to stand it up. Next slide. And automation for deployment and testing. So bugs can be found and deployments can be, or fixes can be deployed quickly. Next slide, please. Thanks. We want to be able to support national projects with platform services like dynamic consent. So maybe a little further ahead, We have DICONs, an architecture for dynamic consent in federated national projects. We're still in the process of prototyping it, but it's informed the decision of Candig's authentication and authorization, especially around service consent tracking and dataset modeling. Next slide, please. Thanks. This is built around an encrypted third binder, which handles interactions between study data and administrative data, keeping those completely separate and reducing the burden of trust on other components in the distributed system. Next slide, please. So, and then here's a couple areas where we've been deliberately sort of upping our game. So we're dealing with an increasing number of data from different data sources and lots of different models. So we've been diligently generating realistic synthetic data for each of these data sets, which makes it much easier to develop ETL pipelines, testing code, testing workflows, doing demos. Next slide. Policies, we've been greatly clarifying policies which are essential around accounts, auditable process, and accountabilities. It's essential for trust. It's essential for clarity of expectations. But we also want them to be documents that can be templates for new national distributed projects starting up. GA4GH policies and recommendations have strongly informed and are sometimes included by reference in our policies. Next slide. Finally, any technical solution, incidents will happen. Our incidents have been minor, and minor incidents are the best ones to start a proper incident response process with. It's really important to get something like that in place so you're communicating lessons and results internally and externally, or else you're not going to learn from the incidents and you're going to keep fighting the same fires. We have a process in place. We've had, thankfully, few run-throughs, and we really need to grow and strengthen this practice. Next slide, please. And this is how we feel we've been supporting 3 of these responsible data sharing principles in the implementation of the next generation platform. Next slide, please. So Candig's growing, which is great, but the Candig growing means there's more responsibility. Next slide. Thank you. So more sites are coming, not all of which will be run by explicitly Candig's teams. That means we're going to have to continue improving ease of deployment, and it probably means we're going to need to reduce the necessary trust levels between sites. We've just heard that there's remarkable advances in technological solutions to support this. Also, governance will play an increasing role. More data sets are coming. That means we're going to have to continue improving our practices around automation, operations, monitoring, incident report response. And we want to enable this stronger role for participants, including but not limited to dynamic consent. So we want to implement DICONs for data programs that need it and can support it with an appropriate level of people's time. Next slide, please. So responsibility has really been a full stack effort for us, and it's a lot for a small team to take on. Next slide, please. Here are some of the areas that have been in the past or are continuing to be pain points for us. The clear division of roles has been a huge help once it became agreed to. And then after that, effective ongoing operation of policies, supporting DACs, routine day-to-day operations of systems, supporting good security practices and development, just the day-to-day things. For software development, again, I want to call out open source software. I think it's essential for trust, but it must be, it doesn't test, scrutinize, or audit itself. Just putting code on GitHub doesn't guarantee that someone's going to do that for you. Careful data handling process at each site, careful consent tracking, the basics. Next slide. And GA4GH has been a huge help for us in this. Sometimes with explicit products we can adopt, and I've listed some of them here. But also, even where there's no product available, we can just take this community that the GA4GH convenes in meetings like this one has been absolutely essential for us in learning best practices, gaining experiences from other team members, from other colleagues, it's really supported us as we've developed this. And that's it. Thanks very much.
Fantastic, thank you very much. Next we have Rachel Hendricks-Stirrup. She is the Research Director leading the Centre's Real World Evidence portfolio. Rachel is a scientist, researcher, health policy and industry professional, journalist and academic within the fields of health policy, business and health innovation, and has served as the Health Policy Council for the Future of Privacy Forum. Rachel is going to speak to us about ethical, legal, and governance considerations in the processing, use, and sharing of real-world data for healthcare and health research. So I'll hand over to you. Thank you.
Thank you very much, and thank you for the warm introduction. I'm Dr. Rachel Hendricks-Stirrup, and as you just heard, I'm the Research Director of Real-World Evidence at the Duke Margolis Center for Health Policy, located in Washington, D.C. in the United States. Today, I will go over some ethical, legal, and governance considerations for real-world data for healthcare and health research. Next slide. So what is the patient-consumer spectrum? Well, that's a spectrum that I identified during my time at working and leading health and genetics initiatives at the Future of Privacy Forum, which is a think tank that is also located in Washington, D.C. And at the Future of Privacy Forum, I contributed to the development of this infographic that you see here that illustrates what the patient-consumer spectrum looks like today in many cases and in many places, such as big cities across the United States, also smaller cities as well, and lots of other places that engage in the technological revolution that we're seeing today in the healthcare space. So the patient-consumer spectrum is a growing concept in which healthcare is rapidly transitioning from a periodic activity in a fixed traditional healthcare setting to rather an around-the-clock activity that involves the generation, use, and integration of data reflecting many aspects of individuals' lives and behaviors. Now, I presented this spectrum during my time at the Future of Privacy Forum at the RightsCon conference. So that happened in 2020, and we received a lot of great feedback on this topic because the spectrum really is an intersection between what we like to consider regulated health data and unregulated health data, really introducing some complexities, both ethical, legal, and social, that we've never seen before. So there are a number of factors to consider, such as, like you see here in the infographic, there are lots of industrial players as well as traditional healthcare entities engaged in this full spectrum of consumer health. That could look like transportation services through the use of an app to and from healthcare centers. It also looks like direct-to-consumer genetic testing on the go or by mail. It also looks like someone talking to a nurse bot rather than an actual human nurse in order to facilitate refill prescriptions, and also to facilitate the exchange of clinical recommendations as well. So again, there's a lot of ethical, legal, and social nuance at play here that's unprecedented, and that is accompanied by a wide array of challenges that we are beginning to see need to be solved moving forward in order to ensure that no one is harmed essentially in the process of health innovation. Next slide. So as I talk about technological innovation in the healthcare and health research space, it implicates what has been called real-world data. There are several definitions of real-world data, but in this slide, I focus on definitions put forth by regulatory agencies across multiple countries and regions globally. First, I'll focus on the United States Food and Drug Administration's definition of real-world data, which is, as they define, data relating to patient health status and or the delivery of healthcare routinely collected from a variety of sources. They describe real-world data as an admixture of electronic health record data, claims and billing service data, product and disease registries, patient-generated data, including home use settings, or at least data generated within home settings, such as Alexa. It could also look like home app data, those sorts of things. And also data generated from other sources that can inform anyone on a person's health status, and that includes mobile devices and other types of personal devices that can collect and share health data at any given moment. The European Medicines Agency similarly defines real-world data as data from EHRs, insurance claims, and data from patient registries, genomics data, not specifically calling out direct-to-consumer or clinical genomics, which I thought was interesting. Also clinical trial data, adverse drug reaction reports, social media, and wearable devices. So social media is an interesting insertion here in the EMA's definition of real-world data, something that we don't often see here in the United States, such as what you see here in the FDA's definition. And also the Association of the British Pharmaceutical Industry defines real-world data as patient data that are routinely collected outside of clinical trial situations. So as you see here, sometimes the definition of real-world data is rooted in the data that is excluded from clinical trials, but rather, or I'm sorry, generated outside of clinical trials, but not necessarily excluded from clinical trials or excluded from healthcare. So the spectrum is very wide. It touches on consumer-generated data that could be of clinical utility, or that could also be of interest to both regulators and payers. Next slide. So what are implications for real-world data across the patient-consumer spectrum? So this illustration here essentially describes or drives home the point that combined uses of various types of data hold, as I mentioned, unprecedented legal, regulatory, ethical, and social challenges, as well as sensitivities that today are largely addressed on a case-by-case basis rather than on a broad policy, enforceable policy basis. Right now, we just see a lot of best practices. There's little shared guidance around ways to enforce those best practices, but in any case, we're at a very early starting point or frontier. So in this diagram, you see that the green circle illustrates data that is generated in traditional healthcare settings, and that is accompanied, therefore, by a regulatory paradigm. However, the data contained in the blue and purple circles represent data that is largely unregulated. And what introduces the most complexity is when all of these data are combined in one or more ways, as the arrows indicate here. And once those data are combined, depending on who's housing the data, it really depends on how the data is being regulated and protected from a privacy standpoint. So for example, if EHR data is combined with direct-to-consumer genetic testing data, it really depends, at least from a privacy standpoint, it really depends on who is housing that data, and what the legal agreements and requirements are to the use and sharing of that data once the data is shared or housed or stored by one or more entities. So the data, for example, genomic data, if it's housed and stored by a direct-to-consumer genetic testing company that offers genetic testing as a health-related product, if that information is shared by a consumer with the consumer's doctor, therefore rendering that consumer now a patient, and the doctor takes action on that data, then there are some blurred lines there. Now, even though the genetic report is housed by the doctor at that point, it's also still housed by the genetic testing company, the direct-to-consumer genetic testing company. So really, it's unclear the extent to which privacy is truly enforced and safeguarded in this particular situation. So this is something to think about from a legal and regulatory standpoint with regard to real-world data across the patient-consumer spectrum, especially as it implicates genomic data. Next slide. Now, another challenge that we're seeing today is open data, especially open data that contains genomics and health data. So open genome data is currently available online. Some examples include Open Humans, the Personal Genome Project as well. These databases include identifiable genomic and patient consumer information, what we would call here in the United States protected health information under HIPAA, which is the traditional healthcare privacy law. And also, we are seeing broad societal implications around the use and analytics of open data, especially as algorithms can be deployed in order to draw inferences around this data as it is publicly available about a particular individual. So from a legal standpoint, the implications to this are currently underexplored. Right now, the literature and also anecdotal evidence suggests that there are several implications to consider. And that's what you see in my final bullet points at the end of this slide, such as lifelong and short-term disability and long-term care insurance companies might have an interest in this data as it's openly available online about a particular individual. They can use this information in their underwriting considerations to therefore deny or approve health insurance coverage for a particular individual and or their family members. Also, some considerations are around home mortgage lending. So if a person's genetic information is openly available online, and if that information suggests that the person is susceptible to a disease that would limit their lifespan, then mortgage companies might have an interest in looking further into a 30-year mortgage application, to the extent that the mortgage lender might not believe that the person will be alive long enough to pay off their mortgage. Also, military service, those who are interested in becoming military members or members of, for example, the United States Army or any branch of the military, there are implications there. And in fact, the military issued a statement in the United States essentially warning active duty members about engagement in direct-to-consumer genetic testing, because it could certainly, the information generated by those tests could certainly be used against the enlistment applicant. And also, there are implications that are unknown for biological family members. So if a single individual shares their genomic data online, it is unknown to what extent that might affect their biological family members, both known and unknown. And also, genomic and health data that's publicly available can be exploited politically, and it can also result in employment discrimination. However, the burden of proof rests on an employee to prove that their genetic information was in fact used to discriminate against them in the workplace. So there's a power dynamic that's also introduced there that is hard to navigate, as some case studies have shown. So these are a few things to consider with regard to open data, to the extent that it includes genomics and health data. Next slide. Now, GA4GH has put forth goals and recommendations on this topic, and they continue to do so by engaging members on the topic. So some of the goals among GA4GH include engaging individuals, or rather interdisciplinary teams, to identify and examine some of these real-world ethical, legal, and social implications and scenarios. Also, there are recommendations to build research capacity to apply novel theories, such as behavioral economics theory, to truly examine ethical motivations or biases that lead or result from broad open sharing of genomic health information across the patient-consumer spectrum, essentially. And also, there are recommendations to engage institutional, state, and national policymakers in these discussions to understand what evidence is needed, what are some actionable strategies that can be taken moving forward, and what are some enforceable data governance strategies as well that are rooted in best practice, where there's an absence of current law or regulation to safeguard individual privacy and other harms as well, not only privacy. Next slide. So here's a list of my relevant research to date on the topic. You can feel free to take a screenshot of this. Should you be interested in reading some studies that I've conducted on this topic that might be of interest to you or your work. And next slide. Here's my contact information. My email is listed here. You can feel free to email me at any time at my Duke Margolis email address, rachel.hendricks.syrup@duke.edu. Thank you very much for all of your time today. And I really appreciate you taking a moment to learn a little bit more about real-world data and its implications for the GA4GH community.
Fantastic. Thank you, Rachel, for that very thought-provoking talk. So we're on to our last speaker now. I'm very pleased to welcome Anna Lewis. Anna is a research associate at the Edmund J. Safra Center for Ethics at Harvard. She is currently working on projects at the intersection of race, genetics, and ethics, and on the clinical rollout of polygenic scores as part of the eMERGE consortium, and also on policy around return of genetic results in research studies. Anna will tell us today about return of results. So I'll hand over to Anna. Thank you.
Hello, it's a delight to be here. Thank you, Alice, for that introduction and for the preceding speakers. So I was invited to tell you about GA4GH's new policy on the return of results, but I'm going to use my time to also make an appeal for a renewed focus on the human in human genetics and genomics research if we're going to have any hope to bridge to health. Next slide, please. So a lot of what GA4GH is about making these beautifully aggregated and harmonized data sets that enable the science that we do. But next slide, please. I think it's easy for us to forget that every column in this data is a human, a uniquely situated individual human with their own complex context. And these are humans who have rights. And as researchers, these are humans that you have duties towards. And that gets us to the return of results. So if we go to the next slide, please. And the fact that there is now an emerging, or maybe more strongly put, an emerged ethical and legal consensus supporting the return of clinically actionable results to research participants. And on the ethics side, there's a really broad patchwork of reasoning, all of which mutually reinforces the return of such results. So on the right side, you've got the right to access, the right to be informed. On the duty side, we've got the duty of care, the duty to warn, the duty of rescue. The value of reciprocity is appealed to. Research participants give us their data. Do they get anything in return? And straightforward appeals to beneficence, i.e. doing good, the opportunity to do some good and help out these research participants. So that's the ethical landscape. On the legal side, here's a review from some GA4GH members back from 2018, where they show just a huge amount of legal mandates to return certain results under certain circumstances. And in the context of genetics research, the Council for International Organizations of Medical Sciences, in collaboration with the WHO, stated in 2016, there's an emerging consensus that at least some findings in genetic research must be returned to individual donors if they wish, and that life-saving information and data of immediate clinical utility involving a significant health problem must be offered for disclosure. Next slide, please. And this return of results is also part of a broader cultural transition in the research enterprise. So we used to talk about research subjects. That sounds like old lingo now. Now we talk about research participants. And some projects have moved to talk about research partners. And we look and expect that there's much greater engagement with our research participants and that we're much more transparent about what we're doing with their data and why. And also, there's a much greater focus on returning value to some research participants. And we know in genomics, partly because of large review done by Danya Viers et al., also associated with our regulatory and ethics work stream, that research participants in genomic studies greatly desire and value the return of genomic results. Next slide, please. But here's the big gotcha. Returning results is hard and resource intensive. Here's a flowchart from a it's currently a preprint from the Genomes to People program about return of results in a biobank. And it's complicated. There's a great many steps that are needed. There's all sorts of things that you need in place, and people with various different skill sets that you need to be involved in this process. And next slide, please. And I think we often see this as in tension with this drive to get as large a sample size as possible. If you've got a finite pot of money, you can spend so much per participant. If you're going to return results, your cost per participant is going to go up, so your sample size is going to go down. And I think that I think we often see it in this way, and I think we shouldn't see it in this way. We should no longer be able to appeal to this trade-off when we think about what we should do for our research participants. So next slide, please. So to tell you about this policy, so this is a policy that has been many years in the making. So I'm showing here my two other co-chairs in putting together this policy, one of whom is my mentor, Robert Green, and Bartha Noffers, who has been deeply involved with GA4GH since the very start. And they first got talking about the need for a policy on returning results many years ago. And it's taken many years to come to fruition, partly because this has been the most contentious of all the regulatory and ethics work stream outputs, the hardest to reach consensus, the one where we've had the most comments from other members of GA4GH and also members of the public. And I'll tell you a bit, try and explain a bit why it was so hard to arrive at consensus on this policy. But why would GA4GH want a policy on the return of results? Well, there's a clear link to its core mission. When data is shared, the knowledge that the initial researchers responsibly address the return of results can reassure data repositories aggregating those data and researchers conducting secondary research with those data that obligations to return results have been seriously considered and addressed with research participants. And data repositories and researchers conducting secondary research may have their own duties with regards to addressing the return of results. But we wanted to take, just as a sort of a starting point, establishing the minimum core obligations for the original researchers. And I just want to emphasize also that return of results within my field, which is ELSI, Ethical, Legal and Social Implications of Genomics, this is one of the biggest topics. We're dealing with a truly ginormous literature and many people who devote their professional lives to this topic. So I'm going to skirt over a great many subtleties and points of debate today. And the focus of GA4GH's policy is on clinically actionable genomic results. That is, results that indicate risk for or the presence of a condition for which prevention or treatment is available. Next slide, please. So the aims of the policy are to provide a reference point for the management of return of results and to identify common ground while allowing for appropriate customization, both by jurisdiction and by specific project. So we have 6 policy points that we managed to all agree on. Next slide, please. The first is the need for a clear protocol that is adhered to. And a lot of this is about planning and accountability. So as mentioned earlier, there are a huge number of moving pieces when it comes to actually returning results to individuals. All of that needs to be thought through in advance, go through the IRB or appropriate ethics review, etc. And also, I think sometimes putting returning results in a protocol and putting it in an informed consent can be taken by researchers to be more sort of permission to return rather than an obligation to return. So it's really also important that the protocol is adhered to and the researchers can be held to account for what they've promised to do in that protocol. Next one, please. And the second one was the need for upfront resourcing. GA4GH has strongly advocated for line items in budgets for data sharing, and we're going to need the same thing for return of results. And also resourcing includes making sure that the people with the right skills for the various different component pieces are available. Next, please. The link to clinical standards. So I'll now quote from the policy. In deciding the parameters for return of clinically actionable genomic results, researchers should be guided by current practice regarding the clinical standard of care within their jurisdictions. So we tend to think of research and clinic as separate endeavors. This link might seem suspicious to some, so we've got a three-pronged justification for it. First of all, it's the prospect of a clinical action that motivates such return in the first place. And it's to support such action that standards in the clinical setting have been adopted. So they seem relevant there. And second, relevant clinical standards will be appropriately sensitive to the health system context, including its cost structure, legal system, and additional constraints of the location of the participants. So to talk about some differences that this might encapsulate, ACMG, the American College of Medical Genetics, advocates for opportunistic screening in the context of clinical whole exome or whole genome sequencing. The European Society of Human Genetics says that this should not be done because of unclear benefit to harm and benefit to cost ratios. Third justification is the blurring of the research clinical divide, suggesting that harmonization could lead to consistency across the continuum of clinical care, clinical trials, research studies embedded in health systems, other research studies, and population biobanks. Okay, and that diagram there is attempts to square the circle, and this was really the policy point that allowed us to achieve consensus on this policy. I'll say more about that later. Next slide, please. Fourth, the need for community engagement. What to return, how to return it. Well, you might well have, if you're a research study getting going, to engage members of your community to work out how best to do this. And this can seem like quite an intimidating prospect, but luckily there's a great GA4GH resource you can draw on for this. If we could go to the next slide, please. Is a new engagement framework, ably led by Mavis, Madeline, and Clara, a framework for involving and engaging participants, patients, and publics in genomics research and health implementation. It enables the consideration of the aims and purposes of engagement and reflection on the strengths, limitations, and likely outcomes and impacts of various approaches for engagement. And it does that by providing a series of reflexive questions for those developing involvement and engagement plans and activities. So that's a great resource that anybody can draw on. Next slide, please. Next policy point, sharing of resources. So when we publish our papers, there's all sorts of things that we spent ages and ages and ages developing that don't always see the light of day. So that this includes our actual protocols, our consent forms, the ways that we've decided to measure outcomes, the tools that we've done to do so. All of these could and should be shared between projects, and this will help lower the barriers to return results to individual participants. Next slide, please. And finally, another thing that helped us achieve consensus is funders are urged to support the return of results. They can set aside resources to support the return of results and those projects that plan to do so. So evidence suggests the existence of a large gap between what researchers would consider best practice for returning results and what's currently being implemented. And additionally, such funding would generate data that we sorely need on cost to benefit and risk to benefit of returning genomic information at all. The gathering of this evidence supports the human right of everyone to benefit from science and its applications, the fundamental philosophy that animates GA4GH. Next slide, please. So here's a question for the audience. What genomic information, if returned to a healthy person who desired that information, would be clearly clinically beneficial to them? So fundamentally, this was what made consensus hard to achieve, because many people in this debate think that when you actually look at the available evidence, this is an empty set across most contexts, that benefits are not sufficiently established for any single piece of genomic information. And we pat ourselves on the back when we find a genetic disease association, and genetics papers are often written as if all that's needed is the last mile of clinical translation to get to benefiting individuals and having a health impact. But that's simply not the case. Finding those associations only gets us to the starting line. And I think this state of affairs should really make us stop and think, has our research agenda been focused on the right things? Next slide, please. So a comment when this policy was going through the steering committee was, oh, this seems, somehow not as concrete as the other sort of GA4GH products. It seems more amorphous. And this wasn't designed as a criticism, but as an observation. Next slide, please. And I think it's because in the research world, we're often abstracting away from the human. It becomes very easy to lose track of the fact that these columns are humans who are messy and complicated with varying contexts that determine the meaning and relevance of their genetic information. And this in turn means that something that's perhaps more one size fits all is not going to work. And we need something that tries to reflect the complexity that is the relationship between each of us to our own genetics. So I'm going to end on an appeal to focus on the human connection, of which returning results is just one part, as a key component of responsible use. Next slide, please. I think our abstractions in genetics research are often too aggressive, and most of the time we don't collect data in a way that reflects that each column in a genetic data set is a human. And the sort of real push and drive and obsession with sample size eclipses this. We often don't set up our studies to learn who might benefit and under which conditions from learning anything about their own genetics, in part because we don't gather enough of the right sort of data to understand each individual's context, and/or we lose that when we aggregate data. So we use the data responsibly when we treat it not as a column in a data set, but as just one aspect of a complex human. And we also will do better science that way, science that has a better chance of bridging from genomics to improved health. And I'll close on that and say that the policy, next slide please, is available on GA4GH's website, and we also have a paper which gives a condensed version of it. With thanks to Robert and Bartha, the Return of Results Task Force, and dozen members of the public for enabling us to get to consensus on that. Thanks very much.
Fantastic. Thank you, everybody. Hopefully everyone can hear me. A bit of feedback. Turn this down. Okay. I can see the questions, but I can't read them. Let me see. That might just be my eyesight. Zoom in a bit. So we've got some great questions, which I think I can read now. Brilliant. So I'm just going to go straight in. I think some of these questions are directed to speakers, but as this is, a discussion, if any other panel members want to jump in, do go ahead. Firstly, Rachel, do you think the COVID-19 pandemic has helped the public feel more comfortable with sharing these kind of data and dealing with virtual healthcare?
That's a great question. I will say that my work, non-COVID related per se, but I will say that my work with the rare disease community has revealed that that particular community, given the rarity of their diseases, yet the urgency for treatment, they are more willing to share their data for health research purposes, mainly because if they don't, then the risks would outweigh the benefits of not sharing. So I would probably assign that logic to COVID-19, such that it could be the case that individuals who experienced adverse health events during COVID-19, they may have been or become more willing to share their data in the event that emergency cases warrant a greater motive to share that data. Now, I can't necessarily cite evidence to substantiate that claim, but I would imagine that that could be the case during COVID-19, such that given that it is an emergency, it could have prompted more individuals to become more comfortable about sharing their data for purposes of identifying treatments and other types of services that could be of benefit to them from a health standpoint.
Thank you. Does anyone else want anything to add before we move on? No. Okay. Anna, but also I think Rachel can add to this. Given how much thought goes into return of results, what do you think about what Rachel pointed out as to unregulated genomic information going direct to consumer through various different areas that Rachel pointed out?
Yeah, well, I'll say two things. I think firstly, I think some of the direct-to-consumer genomics companies that return health information actually do a really good job of contextualizing that information and packaging it up and making it understandable. Probably a better job than many labs do. Although, so I think they sort of realize the pressures of what does it take to make information relevant to a person. I think they take that side of things, or can take that side of things, very seriously. But the other thing I'll say is that I think that it's quite easy to sell snake oil in this field, and I think that our attitude to publishing genetics research makes that easier rather than harder. So we have these polygenic risk scores that capture a tiny % of the variance of a trait in a population that make a big splash in the science side of things, and we don't talk so much about the actual effect sizes. And then you read the sort of press releases of the companies that are then selling them, and you see how they got exactly from the way that we talk about the research. So I do think that there's problems with how some genetics is sold to consumers, and I think we could take some more responsibility for getting sort of the significance of the results better across.
Fantastic, thank you. Okay, we'll move on to the next question. Okay, JP, you said the robustness of the method scales with the size of the federation. Is it therefore relevant for smaller consortia?
Okay, now maybe this was a misformulation from my side. What I mean is that the kind of techniques I've shown means that as long as one of the centers is not corrupt, the whole system is robust and is protected. So, which means that since there are 3 centers, it would already require the attacker to compromise each of the 3. Now, if there are 20 centers, it makes, of course, the job of the attacker even more complicated. This is what I meant, but I would say that even with small numbers, this kind of solution is considered to be robust enough and way, way above the kind of protection that are provided by existing systems.
Great. Okay, so related question for Jonathan. Can you imagine a use case for homomorphic encryption with Candig?
Oh, yes, absolutely can. We looked into this early on as a proof of concept using much less state-of-the-art approaches than we saw today. I think absolutely. As we grow to the federation size and have less trust between sites, or even less trust between projects across sites, I think it could be very useful. We also looked at differential privacy, which solves a mostly different set of problems. But for us, it was about also supporting potentially less trusted users to still be able to do certain discovery or analysis problems. So I think both of those approaches make a lot of sense as we try to scale the impact.
Great, thank you. And another question for you, actually. Does DICONS, the dynamic consent, reuse jury products, like, for example, GA4GH passports and Duo? And do you have any feedback for others on what prevents adoption or works well, depending on the case?
Yeah, so I think in terms of use of jury products, yes, we're tracking developments on Duo very, very closely for tracking and documenting the consent, and not so much in DICONS, but on the authorization side of things, we're using not whole passports, but passport visas as claims for tracking the entitlements of a research user. So I think in terms of adopting those jury products, I think there's a lot of interest, and I don't think there's big roadblocks.
Thank you. Okay, jumping around a bit more. Sorry, I'll try and make this understandable for everybody. But JP, you said that auditing open source software is essential. What advice do you have on effective audits, and what body conducts them?
Yeah, so indeed, open source software and its auditing are there typically to reinforce trust and to find bugs, right? As we know, nevertheless, there are well-known examples of, for example, internet protocols that had been used for years and that were open source, and that bugs, actually vulnerabilities, have been found at a later stage. So it's not an absolute guarantee, as we know, right? So achieving security is very tricky. So typically, peer reviewing is something that can be very, very helpful. But there are also companies that you can pay, and they make an audit for you. Again, it's not an absolute guarantee, but if they are able to line up the appropriate specialists, it can be a very, very significant help for the identification of residual vulnerabilities. So I think one has to take all these kind of precautions, and there are additional precautions to be taken, such as, for example, pen testing is something that is done very routinely in hospitals. So running really batteries of, let's say, simulated attacks to identify vulnerabilities online. White hat kind of scenarios is something that is also very helpful and is actually recommended practice.
Great, thank you. Okay, Rachel, what would you consider effective policy to both protect patient privacy rights while also supporting the value of data sharing for the broader good?
That's a great question. I think privacy regulators are still trying to figure that out. And when I say privacy regulators, I mean across multiple countries, not just in the United States, and then also within the United States at various state levels. We are seeing some movement at the state level here in the United States, where Colorado, Virginia, and California have implemented comprehensive privacy laws that intend to protect various types of what I call patient consumer data. But really, that is limited in its effectiveness, clearly, because that's only 3 states out of 50 plus. And also globally, we see the General Data Protection Act in European nations, where patient consumer spectrum type of data are included as sensitive categories of data. But again, a lot of these laws focus mainly on the type of data and not necessarily on the uses of data. So there is a fine line to walk there. It is important to categorize or classify certain types of data as a protected or sensitive category of data. But even then, when that data type is made available to the public, as I discussed or illustrated with Open Humans and the Personal Genome Project, there are different implications to consider there from a privacy protection standpoint, at least privacy protection that's legally enforceable. So there's lots of nuance there. And again, they're still trying to figure this out. Even when thinking about genetic data or genomic data, there hasn't, or at least there's not a lot of agreement even in the definitions of those terms. So still there's a lot of work to be done from a nomenclature standpoint in order to understand what protections should accompany what types of data, and then moving on from there, in what contextual situations are these laws enforceable or not. So there's a lot of work to be done, as I mentioned, in this space. And I think the GA4GH community is well poised to at least inform some of these legislative or policymaking conversations and decisions being made on the topic.
Thank you. I wanted to jump to this question next because this came in when you were talking, Rachel. I think it's for you, but could an economic model that incentivizes all participants be created? I think that came in when we were talking about real world data. JP, sorry.
I'm happy to volunteer for this one because we have devoted a lot of thoughts to this, and I've also published extensively on game theory in prior research. So the thing is the following: is that if you think about it, right, take the simple example of collaboration between two sites, A and B, right? With the conventional approach, data are transferred either from A to B or from B to A. If A transfers to B, essentially A loses control of their own data, and vice versa. So there's a disincentive in the current situation. With the kind of tools that I've mentioned, with federated learning, where data are not transferred anymore, then everyone benefits without losing control on their data, and the game remains fully symmetric. And one can show that it is possible in this way to move from, let's say, a non-cooperative Nash equilibrium to a Nash equilibrium that becomes actually cooperative. So this, I think, is going to be a big, essentially, game changer in this on the cooperation landscape.
Great, thank you. So Anna, is there a need for guidance to help researchers return results so that participants can appropriately gauge the weight of these results?
Yeah, so when we say researchers, it's not the same people who are plugging away at the code. Like usually you would set it up so that somebody like a genetic counselor would return these results. And I don't think what we're lacking is guidance. There's a lot published out there, lessons learned from all sorts of different projects, general best practices for returning genetic results to individuals. What we're missing is the will to actually do this. Like, it's complicated, and it's just easier not to do it. That's the thing that's got to change. That's the thing we're missing.
Okay, and an additional question: how do you think the best way to overcome that is?
Yeah, that's a good question. I think that we can all do a better job at raising eyebrows when somebody's launching a new project and not wanting to return results. I think the other thing is that we can generate data which actually shows that returning genetic results to individuals is beneficial. Like, isn't that just a damning indictment of the whole field? That there's no consensus, nobody can agree on a single piece of information in the genome that it would be beneficial to return to a healthy individual. Like, I think I find that kind of shocking. Like, the promise of genomic medicine seems to always be around the corner, and it's still always around the corner. So we've got to also change that and convince more people that it can be helpful to individuals to receive genetic information about themselves.
Thank you. Well, I think that's an interesting point. We have just different parties would, I think, have different perspectives on the usefulness of the data. But in the interest of time, we will move on to the next one. So, Jonathan, you wanted to make it easier. You said you wanted to make the process of what you were doing easier than other national projects in Canada. Have there been any similar initiatives, and what specifically did you do that made it easier?
Oh, there's definitely. So yeah, there's a couple of things in terms of supporting other research data projects. I think these policies have definitely started conversations more easily. I think it's still pretty new yet, but I'm pretty confident about that. In terms of supporting other infrastructures, other platforms, there definitely have been others, and will continue to be others. Right now, maybe the biggest impact, right now we're helping with the Digital Health and Discovery platform, a slightly different infrastructure project across Canada. And I think that the policies that we've put in place, the division of roles and responsibilities, has really helped clarify the division of roles and responsibilities between DHDP and one of the flagship projects it wants to support. So yeah, I mean, this work is this policy work, and this policy work supported by GA4GH is really important, and it does speed up, does accelerate other efforts.
Thank you. Okay, that's next. JP, the question, oh, there it is. This person wasn't quite clear on the amount of work needed at the remote endpoint site, e.g. an existing cohort.
Okay, so the way this works, so there is a certain number of data providers. So each of them is, for example, a hospital that is part of the confederation. So each of them has to prepare its own data sets. So it's essentially the ETL procedure that requires homogeneity in the way the data is formatted across the different sites, and let's say homogeneity in terms of ontologies. We know that unfortunately this is not cannot be taken for granted. So in some cases, adaptations that are needed. It helps if the hospitals, or let's say data providers, are already using something such as I2B2 or Homomorphic Odyssey, or something that is essentially first step in that direction and will facilitate the overall consistency of the system.
Thank you. Oh, there's another question for you here, so we'll go straight into that. Can Medco's federated analytics capabilities be translated into new GA4GH standards that anyone can implement?
Absolutely. So this is something that that can be done, and so we have had a number of discussions, notably with the colleagues of the CloudWorks stream. It's still maybe a little bit of it ahead of its time with respect to the metabolism of GA4GH, but I think very soon, actually, it has to happen at some point. Or it can be Medco or something of in the same league. But it's certainly a conversation that deserves being pushed further. And so in the slide, I've just tried to sketch how it would look like, but there's clearly still work to be done to refine the related APIs in particular.
Thank you. So there's an open question to the panel here. What are the best examples the panel have seen of projects explaining data security issues and risk-benefit of results to participants? Would anyone like to go first?
I think that's a really good question. When they say, or at least when the audience member asks for, particular examples, I think one example that I brought up is within the rare disease community, where, quite frankly, the privacy and security risks to data sharing, they simply don't outweigh the benefits or potential benefits for this population. So I think we have to approach this question or person even in mind, because that's certainly not a question that I think can be answered with a blanket answer. It really depends on the situation. It depends on the urgency of the situation. We talked about COVID-19 being another example of those urgencies. And I think from there, we're able to better contextualize examples where data security issues simply don't outweigh the benefits to data sharing or return of results.
And if I could, yeah, agree with that. This is part of this issue that what the risks and benefits are depends sensitively on the context that somebody finds themselves in. So it's not going to be possible to have a, like, you know, in all cases, you know, this is what the trade-offs are. And what that means is that if you have your own situation and you're thinking about what the risks and benefits are going to be, then you're going to have to find the things which are most similar to your setting. And there have been some studies that look at this translational piece, and you can find them in the literature. So, for example, in the US, for like more sort of general populations, there's the CSER consortium, which have published a lot on this. And depending on the country and then depending on the particular community, you can dig in deep. But I would agree with Rachel that there's no one-stop shop.
Thank you. Okay, we'll move on to the next question. We've got a few more minutes, so hopefully we can cover a few more. Anna, as part of more open research articles, is it not possible to include all of these resources that you mentioned, like the protocols, the consent forms, etc., in that process?
I think that could be a great mechanism to doing some of this resource sharing, and it relies on people actually doing that and taking advantage of these more open platforms' abilities to share various different types of information. So yes, even fewer excuses not to do this.
Thank you. Okay, so a question from Tommy JP. What is the software licensing support model for a data federation based on Medco encryption?
Right. Hello, Tommy. Yeah. So we have tried as much as possible to have it open source. And actually now there are different, as we know, different variations of open source, and not each module has exactly the same license. So I'm happy to provide you with details, but I don't want to bother the audience with, let's say, technical considerations about this the licensing issues. So, but please drop in an email with your specific questions. But essentially, the goal is to be as much as possible open source, and in such a way that this can be also open to the scrutiny of the community.
Great, thank you. Okay, I'll try and get through a few more. What have we got? Okay, JP, federated database data models may not be compatible. It looks like there is still a need to query move some of the metadata before running an analysis. Yeah,
well, this refers to something that I already mentioned, right? That there is indeed an effort that has to be made in some cases where there is not enough homogeneity in the data formats. And so the metadata aspect has to be taken also into account. Yeah.
Thank you. Okay, we've done that question. I think this is the last question for JP. Does Medco use I2B2 as a native language, or is it just as easy to use to move to OMOP?
OMOP, yeah. So actually, we took I2B2 just as an example. It's not that we are particularly enamored with that with the tool, but it exists. It does the job. It is very widespread in a number of US hospitals. It is also somewhat used in Swiss hospitals, not everywhere, however. So we just took it as an example to show that that it works, that what we have done works and can be plugged into existing platforms. But of course, it could be replaced relatively easily in order to take, for example, OMOP, if people prefer that. Absolutely.
Thank you. So we're at time. There's a few more questions that we can aim to answer offline, but I think that brings to the end our session. And thank you very much to all the speakers for those fantastic talks and really thought-provoking ideas, and for all the questions. We had lots of questions, so thank you everybody for submitting those. We have a break now. Now let me check the time that we're coming back, which is in various different time zones. It's a 15-minute break. So let me hope I get this right, but we'll be back at 5 to whichever in your time zone.
Right. Welcome back. It's great to be here. And we are on now to the session track 3 on real world implementers. So we've got a great lineup for you. And first off is Tommy Nyroen. Tommy is the head of the Elixir Finland node from CSC. And he has been instrumental in bringing life sciences to computation and computation to life sciences in the context of both the big compute projects across Europe and in the context of Elixir, the European-wide infrastructure focusing on computational biology. He has participated in many different parts of GA4GH, and most importantly, he is one of the work streams leaders for the jury workstream data use and researcher identities. So welcome, Tommy, and looking forward to hear your talk.
Thank you, Ewan, for the introductions, and good evening from Helsinki, Finland. So my talk today is about end-to-end implementation of GA4GH standards in the European setting. So what we are building in Europe is highlighted in this presentation, and I'm trying to approach this both from the top down, like the government viewpoint, and then from the technology up, and trying to make these two ends meet. So this is a story about that development taking place as we speak in Europe. In the next slide is an outline. So basically I have these three things on my mind. So I'll introduce what the EU 1 million genomes initiative is, and then I'm going to tell about the focus on the infrastructure that I'm leading with Finland and Sweden are leading, and we are trying to put together a proof of concept with the rare diseases use case, the kind of questions that what rare diseases would like to ask from federated genomic datasets if they are made accessible for them. And then I'll summarize with where we are and what are the next steps that we are planning to do in the European initiative. So on the next slide, you'll see that the declaration was signed by the governments and the ministers already a couple of years ago. So it has a pretty broad coverage across Europe. There's a lot of, if you saw the last session where Jonathan Darcy was speaking about the Canadian distributed genomics infrastructure, there's a lot of similarity in the technology and the regulatory aspects in Europe. But of course, in Europe, it's maybe a bit more complicated because each one of the countries wants to enforce their own regulation on the sensitive data that they have. But here we are, and the goal has been set that by the end of 22, there should be proof that at least 1 million sequenced genomes would be accessible in the EU. And on the next slide, we can see that the aims are really high. So the member states, the governments would like to ensure that there's appropriate technical infrastructure available across the EU. And so I'm really trying to make this very broad goal setting by the government people into smaller pieces that could be tangible and could be dealt with. This has to be, of course, compatible with all the different regulations that are present in each one of the countries, and also the regulations that are coming up. Like, for instance, EU is trying to set up data spaces, and this is a very broad like a concept that they want to drive in the next year or so through the regulation. And these data spaces cover the health data space, and of course the genomic data is, in my view, part of that space. And these are the kind of regulations that are changing as we're trying to figure out what is the needed appropriate technical infrastructure for this. Of course, there has to be also increase in the public understanding of what benefits could be gain from having genomic data as part of the medical decision making, and we have seen great examples in this plenary already on that. And of course, this will be measured if the healthcare systems pick up what is made available to them, and if these data can really be part of the decision-making processes. So these are the aims of the signatory member states. So when we take this down in the next slide to the infrastructure level, so we have sort of interpreted this mandate that what we need to do is to provide standards for interoperability to facilitate, have different interfaces taking place for this cross-border data exchange. And it has to be secure, of course. Nobody can lose face or reputation. So security has to be built into the services, infrastructure services that are being designed based on these goal settings. And we are approaching this because, I mean, as I said, the regulations are changing as we're trying to figure out what infrastructure to build. So like in CanDig, we are approaching this with a synthetic data set that resembles a genomic and phenotypic clinical phenotype register data as close as possible, but not real data. So we're trying to manage that with the systems that we're building up and try to make the technology development take place quicker with this approach. So then here you can see already that the GA4GH standards will play a role, because we need to have standards that we recommend each one of the countries or the data hubs to take up. And this hopefully will lead then into the increase of our capacity to manage and process sensitive data. Next one. So next one, please. So the next slide is so the assumptions that we made 2 years ago and which were endorsed is that the Million Genomes data cohort or virtual cohort will exist as a distributed system. So there will be data hubs that will need an interoperable solutions. The countries are very independent and they need to have the freedom to organize their own data hub. But we need this interoperability reaching from technical to semantic to organizational and regulatory levels taking place. And in order to do this practically, we need a contact point in each country, a data hub who could help us build this infrastructure proof of concept. And that will be the next slide. No, so now is the real content of this talk. So the proof of concept. So basically what we have done is we have chopped the word infrastructure into 5 smaller pieces, which are data discoverability, data reception, the physical hardware like the storage and its interfaces, data access management tools, and then processing. And the ones in the dashed box, those are the real ones where we need technology development to take place so that we could have these functionalities. And with these, we have made like a scoping exercise, and the set of standards that we are intending to propose are being implemented for the rare diseases use case. So in the next slide, you see the questions that the rare diseases posed on us. So basically, what we would like to do with a handful of European countries is to show that if you ask questions that the European Reference Network on Rare Diseases would like to ask so we asked this question from the European Reference Network, that what kind of questions you would like to ask on data if it's made available. So we created this data set for 2 data hubs that sort of act as examples, and these are in 2 countries, Finland and Sweden. And you basically can't answer these questions unless you access data in both of these data hubs. So then we imagine a user or researcher coming from Spain who needs to do all these steps on the infrastructure functionalities. So they need to discover, access, and analyze data in order to have the questions ready. So in the next slide, you see the questions taken apart. So basically the idea is that the synthetic data set contains some genetic variants that lead to a particular clinical phenotype, which is the number 1 and 6, and I don't try to pronounce it now because it's late evening in Finland. But basically the idea is that the data discovery happens first by discovering a particular variant, but then there has to be an additional discovery taking place at the level of a relevant clinical phenotype. So each of these discoveries, when they take place, then the researchers realize that they should get a deeper access into this data. So that's what they're doing. In the next slide, you shall see what we have built for the proof of concept. So basically, now the top layer, you see the functionalities that I mentioned. So reaching from data discovery to data access management and processing and so forth. In the down lowest layer, you see the Global Alliance standards that are needed in order to implement each one of these steps into the technical infrastructure systems. So in the middle, starting with the green and red start and end graphics, you see the open internet access leading to registered data access and controlled access. So all this process has to take place as well in order to facilitate this distributed data access. And then on cyan color, you see some of the software tools where these different standards are being implemented. I don't go into more details because this is a rather technical figure, but on the next one, you'll see that Beacon is one of the softwares. We're waiting for the Beacon version 2. And meanwhile, while we're waiting for this, on the next slide, we're using also Matchmaker Exchange, and this is needed to match the clinical phenotype so you can discover the data in the right way. So one particular feature for many of these softwares is that we need to be able to support this distributed setting. So this is kind of a politically driven thing that countries want to be independent. So distributed infrastructure is kind of the complexity we have to deal with in this setting. But nevertheless, the functionality of the Matchmaker Exchange and the functionality of the Beacon version 2 might be complementary. So I don't know if we need the Matchmaker Exchange after Beacon version 2 comes up. In the next one, there are some particular technologies that come from Elixir and Finland. So particularly, I'd like to mention the Elixir identity and access management infrastructure. The key point here is that we support authentication authorization across multiple and diverse identity providers and the access rights. And the access rights that researchers or users can gain, they are encoded using the GA4GH passports. The users, when they are confirming who they are and where they come from, say they do this via their institutional identity providers. So we are kind of relying that the institutional level of assurance that people are who they claim to be is enough. Whether this is enough is something that we are trying to figure out as well. But I mean, without this identity proofing taking place, you can't add on these controlled access grants that could be interpreted downstream on the distributed infrastructure. You cannot rely on it. So this is one of the key components. The next key component is resource entitlement management system. So this is basically the one interfacing with the data access committee processes. So you can record incoming data access requests. So for instance, we're using this in the Finnish biobank system to track the samples and the data from the Finns, and all the data access decisions are recorded in REMS. And the REMS can write the GA4GH passport format on what decisions have been taken. And this information then in turn can be consumed on the compute platforms that hold the data and can provide the computational access to the data. And the next one, so I don't go into these details, but I mean, like these are some of the things that we are requested to fulfill. Jean-Pierre who both told about the data protection impact assessment, that we are in the middle of that. And basically these questions that are here come from the regulatory requests. So the technical infrastructure needs to match those requests, while at the same time we need to be building this thing. So it is a kind of iterative process between the technology and the ethical, legal and societal experts, the lawyers. So we're trying to talk between the working groups in the Million Genomes very actively, so that the regulators don't try to regulate something that we cannot implement on the technical infrastructure side. So I think this is one of the crucial messages of these slides. These are really complex requirements for the technical infrastructure. The next one, so the remainder of the slides just shows where we are at the moment. So basically, we are having active coordination as a project, but we are relying on adoption and implementation on the existing efforts, such as Elixir and the European Open Science Cloud and GNEGA project and European Joint Programming on Rare Diseases. So these are all funded projects, and we're trying to get the technologies and match them to this high-level picture that Million Genomes wants to drive. And the next slide shows that we have sort of defined the requirements from the initial political guidance into a deeper level. We are now driving, translating those discussions in order to reach this goal by having 1 million genomes accessible by 2022. And the next slide. So this is basically where we are. So what we are aiming for is that by the end of this year, in December, we would be able to fully publish this proof of concept with the rare diseases use case queries using these existing components that come from the projects and are coordinated together in this Million Genomes effort, leveraging the tools that I told, like the Beacon, the Elixir, AI, REMS, and the genome phenome analysis platform from the rare diseases. It's still more like an exercise or integration. It's not a service, and we're trying to explain this very, very carefully for the government people making decisions for the future of these data infrastructures. So if we get approved, we will move into other use cases as well, like infectious diseases and cancer. But we need some sort of milestone decision here in the turn of the year, so that the governments themselves say that we are trying to do with this proof of concept what they intended with the original 2018 declaration. So we're trying to link to existing projects, and I think I'll be in contact, especially with the Jonathan Darcy about the CanDIC and see that we can learn from their work. I think and there's the next slide just acknowledges some of the projects and partners. So this is, I'm really me standing in front of like 50 people from Europe who know many of these things in great detail. And I thank you very much for your attention and for the opportunity to present 1 million genomes here. So thank you very much.
Great, thank you, Tommy. And as is traditional, we're going to have a Slido moment and a little bit of time for the Slido questions to come up. Here we go. Join on your Slido. So Tommy, whilst people are thinking about putting questions in, that example of the kind of story that you have of the Swedish and Finnish data sets and the researcher from Spain, does it work? Does it work for a simple query now, or is that the endpoint, or is that working now?
So that's not the endpoint. So the endpoint is that a researcher would get a genome browser view, and so the question is really that are these variants connected to a clinically observed condition. So basically, we're trying to provide an endpoint where the user could start thinking about that. So I guess the endpoint is some sort of a genome browser view, or
I see, with credentials that you then log in through the browser view. Right, we've got a question. So, Tommy, you talked about AAI, but yes, but are you implementing GA4GH passports? It does go to, do you mean that it is GA4GH passports, or is it a different flavor of AAI?
Yeah, so yes, we are implementing GA4GH passports for this demo, so that all the access rights are carried with the GA4GH passport format.
Okay.
And Elixir AI is the GA4GH passport broker, and the data access rights are sent in by the Finnish and Swedish DACs that are part of that. So the Spanish researcher comes in, sends a data access request to both of these DACs. We gather the information in REMS, and this is then sent to both of these genome phenome analysis platform endpoints. Then the researcher can do their job. And like Ewan said, the endpoint is something like a genome browser where you see the variants that you have discovered that might explain this clinical phenotype.
Great. And a sort of similar, almost broader question, similar to mine though, from Serpa here. Tommy, good vision. What is needed to make it really work? What are the major obstacles? So I guess you could break that down into two parts. You know, how confident are you that this all works? And then what are the things that may make it not work?
So I think it works on laboratory. like we can make it work. So I mean, all these software pieces, they work already, but they are not service. So basically, if you start building a infrastructure on this, that you have 5 or 6 or 22 countries, so each one of those countries should promise a service availability and interface availability and incidence response system and help desk and whatnot, and we don't have that yet. So basically what we need an example of few countries who can start this federation of data, who have experts who can get this done, then see what it sort of takes from staff and divide the work. And, you know, all this division of work things that Jonathan Darcy was talking about, this is also a reality in Europe. And of course, somebody has to buy into this. And this is maybe those who drive the declaration.
Okay, perfect. Well, thank you very much, Tommy. That is wonderful. It's great to see Europe's beyond 1 million genomes really becoming concrete in this. And I think we're going to shift to the next speaker now. And I believe there's a slide coming up. Is there a slide? Or do I just... right. Here, okay, here we go. The next speaker is Alyssa Manning, who is from the Mongan Institute at Massachusetts General Hospital, and she is associated with the metabolism and data science programs at the Broad. Alyssa studies, unsurprisingly, metabolism using genetics such as type 2 diabetes. Alyssa, I hope you're, I believe you're on, and we're ready for you to give a talk.
Wonderful. Thank you, everyone. So the title of my talk is Opportunities for NIH Cloud Interoperability Approaches to Improve Outcomes of Pediatric Diseases. This work has been done in collaboration with multiple NIH stakeholders, including NHLBI's Top Med program, the NIH, which is the Gabriel Miller's Kids First Pediatric Research Program, and the NHLBI's Biodata Catalyst. Next slide, please. So to set up our problem, I have a research question and an analysis plan. Some aspects of the analysis will always stay the same, and I will obtain approval to use some data sets by submitting a data access request on dbGaP. I will set up a place to do my analysis, which will follow the training and authorization policies of my institution. And as a principal investigator, I will be managing my research team to ensure that the data is used properly. Next slide, please. In the past, we would use dbGaP functionality to find data sets, submit data access requests, download and decrypt files, and write the scripts and documentation on how we organize the files for analysis. We could perform the analysis on a local computer system or a high-performance cluster made available by my institution. Some disadvantages of this approach, unsurprisingly, are these slightly annoying steps and dealing with very large files, and the inability to work directly on programming code and analyses with approved collaborators. So each researcher is doing analysis on their own. Next slide, please. So now I can use portals in NHLBI's Biodata Catalyst, the ecosystem, to organize and access data associated with my approved dbGaP data access requests in Gen 3. I can export links to large data files to an analysis workspace, which has tools, apps, and workflows that enable me to implement my analysis plan. I can easily share my workspace with my collaborators at my institution or from other institutions. And importantly, there is an automatic check for permission to use the data when I access files from my analysis workspace. So while I am managing the use of my data by myself and my research team, these features enable me to get to my analysis faster and easily so that I can focus on the hard part of my work, the research question. Next slide. The NHLBI initiated Biodata Catalyst around 3 years ago to address the needs of the heart, lung, blood, and sleep research community. The mission is to develop and integrate advanced cyber infrastructure, leading-edge tools, and fair data to support NHLBI research. The vision is to be a community-driven ecosystem implementing data science solutions to democratize data and computational access to advance HLBS science. So within Biodata Catalyst, our development efforts are purposely user-centric, keeping us driven on scientific outcomes. Next slide, please. As I mentioned, Biodata Catalyst is an ecosystem of platforms that have been brought together as a secure cyber infrastructure for users. So within this ecosystem, a user can search and browse available data, access workflows, and use the TopMed imputation server. Next slide, we're going to dive into the proof of concept that I'll be presenting to you all today. So the goal of this particular analysis is to bring together the Pediatric Cardiac Genetics Consortium study data for the first time in the cloud for researchers. So this is a project that's based on real data access from the researcher's perspective. And I've taken the route of not the development route, but the researcher route to perform this analysis. Our scientific question is to investigate genetic factors related to congenital heart defects in a study design that uses healthy controls from 2 NHLBI cohorts. And we will, the data, additionally, some data that we wish to use are the Pediatric Cardiac Genomic Consortium's observational study of participants with congenital heart defects. So these are a cohort of cases that we can use in a case control study design. This cohort has non-overlapping whole genome sequence data available through both the Kids First data resource and the TopMed study, and thus Biodata Catalyst. And we will use the population cohorts, the Framingham Heart Study and the Jackson Heart Study from TopMed as controls of individuals who are from a population-based cohort and can be comprise a sample that can be used to select controls for a case control study design. Like I said, these data sets are available on either the Kids First data resource or Biodata Catalyst. Next slide, please. Our study aims are to identify, access, and summarize available genetic and phenotype data on native cloud platforms. We're going to leverage individual level data from multiple cloud platforms to assess rare variants contributing to congenital heart defect risk. We will accomplish these aims by applying a method called ProxyCat, which will allow us to compare the ratio of rare synonymous and non-synonymous variants per gene between cases and controls. And next slide, please. So we want to set up a place to do analysis. And given the paradigm that I've already described, where the data exists on one platform and not the other, and is not accessible from one platform and not the other, I'm going to describe the workflow that we go through for this particular analysis. So I'll point out that this is not the ideal, and I'll show you the current paradigm, which enables a much smoother and smoother process for doing this. But this is where we were about 6 months ago, and I will highlight where we are now. So we set up places to do analysis. We're on NHLBI's Biodata Catalyst, and we're on the Kids First platform. Could you go to the next slide, please? We have authorization to use data, an approved dbGaP application that describes how we're using the various cloud platforms to perform an analysis with the data available from the 2 different cloud platforms. We are restricting this analysis to rare variants, and we're just going to consider within the whole genome sequence data, we're going to consider the protein coding variants in the exons of genes. All right, next slide, please. We've performed platform-specific summaries. We've got controls from Framingham Heart Study and Jackson Heart Study. As you can see on this, the left-hand plot, indication of the distribution of age among individuals in these 2 cohorts. And then on the right-hand plot, you can see from an analysis of the portion of the PCGC data on the Kids First data platform, we see a distribution of age for the individuals who are participating, who are part of that program. So doing analysis on each platform separately, gaining the appropriate genomic summaries for the method we are going to apply was not ideal, but it was our way of using the cloud platform. Can we go to the next slide, please? So we performed our final association analysis using summary statistics obtained, copied over basically from the Kids First Data Resource project into a Biodata Catalyst workspace, so that you can see the results that we have here in our pilot analysis. What we have are more than 17,000 genes tested, a number of genes with a statistically significant p-value, but if we restrict to the genes that have known associations with congenital heart defects, 1 gene does actually pop up as being statistically significant. I will say that because this is a pilot analysis, we are now going to work with researchers from the PCGC to investigate any potential novel signals that we observe here. But the point wasn't the results that I'm showing you here, but how we got to access to the data and were able to analyze the data and then perform our final analysis. Next slide, please. So the goal of the NCPI Systems Interoperation Working Group is to complete the connections of data indexing, data access, and authorization between analysis workspaces and the portals that displayed here that include Biodata Catalyst and Kids First. So now we are we can benefit from the completion of these connections. And some of the work that I had previously performed on 2 workspaces, the Kids First workspace and then the Biodata Catalyst workspace, we don't have to do that anymore. We can do work directly from a single workspace such as Terra. Can we go to the next slide, please? So here I'm beginning to summarize and in the last few slides of my presentation where we were before there was an interoperability effort And then current paradigms, which is the example that I showed here, where we did data pre-processing in separate workspaces with individual ecosystems, and then a final analysis in a single biodata catalyst workspace. Now, if we go to the next slide, please. Now within the Terra workspace, there is now the functionality to link your identity with external and identifiers that include both Biodata Catalyst and Kids First Data Resource Center. And so now we have the ability to obtain dbGaP access to data sets and then access and localize these to a single cloud platform and perform all the analysis in a single component of the Biodata Catalyst ecosystem. And if you go to the next slide, I will acknowledge the many people that participated and contributed to this project. And obviously we'll take any questions that folks might have.
Right, that's great. Wonderful. So we've already got some questions coming in. So Elisa, first question, is there an opportunity for international partners to get involved?
I think that we will all benefit from open standards developed by GA4GH and APIs that will allow the connectivity between platforms. Ultimately, any use of data has to be proper according to the data use for the data use limitations for a data set. But these systems and that we've been able to build so far do provide a wonderful path forward towards federated portals and the ability to talk to servers on various sides of the Atlantic, perhaps, and pass data back and forth smoothly. So I would say that if there's the will and the willingness for the policy considerations, which will probably be the most difficult component of all of this, then the technical solutions will have been established.
Okay, that's great. And I think it's not just the Atlantic, it's the Pacific, and it's the North Atlantic.
The entire world then.
Yeah, the South Atlantic and the Indian Ocean in there as well. But that I think goes to a good question. Which are you utilizing any GA4GH standards in your system? And if not, I won't ask you the harsh why not, but which standards do you expect to utilize first?
Absolutely. I had to cut this part out of my presentation due to having only 15 minutes to present, but we use Darcy standards within this interoperability solution, RAS, and also there's a moves towards developing the passports, RAS passports, and I think that's a good summary of what I know from my perspective where we've implemented.
Great. Okay. So and that I think we've got a couple more questions. So do the multiple identities work in 7 bridges? Does it work?
Well, this proof of concept used Terra as the focal point. I think from the NCPI there are efforts from both 7 bridges, Terra, and Gen 3 and other teams to get the interoperability all around, but I'm not investigated the 7 bridges connections.
Okay, that's great. And then there's this question about data models, and I think that's less on the genomic side, but more on the kind of phenotype side. How do you think about people doing federated queries where immediately the question is what what do I even query on this side relative to this side? Yeah.
Right. So having different data models in the different data sets is a real problem. And within a particular platform, we've solved it by having analysis workspaces that are specific to a particular data organization or data model. And then with it, using a separate workspace to pull in the particular components from the other workspaces that we want for our analysis. So I believe that it wasn't a major stumbling block for us, but it's an important consideration when the data is organized differently. And I think every researcher will have to decide the optimal organization of their data for their analysis. But the workspaces make it quite flexible to do so.
Okay, that's great. I think there's a comment. So yes, Ian was saying that this should all be possible via DRS and WES, which is there. So I do think this whole business of yet more interoperation and real world interoperation is great. I look forward to the first transatlantic passport acceptance as well, or trans-Pacific passport acceptance as well. So with that, thank you very much, Elisa. And next up is Mamana Bivianga. I've no doubt mangled your name, Mamana. I'm sorry. Mamana is from South Africa, University of Cape Town. He is a leading member of the H3 Africa Bionet project, doing the bioinformatics network across Africa. And he has led and been involved in various initiatives that aim to supply responsible access to genomic data across Africa and integrate it with the world. He helps coordinates H3 Africa's activities as part of GA4GH and the Sinica project. So welcome, Mamana, and to the session, and over to you.
Good day, everyone, and thanks very much for the opportunity to present in this meeting. I hope that you can hear me very well. So I'm Mamana Biavanga. I'm from the University of Cape Town, and I'll be presenting on behalf of the H3 Africa, which is one of the GA4GH driver project championed by Nikki and Mogo. And I'll be talking about leveraging the H3 Africa infrastructure for effective and responsible genomic data sharing to accelerate genomic research in Africa. Next slide, please. So be quickly taking you through an overview of H3 Africa and H3 Bionet, just to make sure that we all at the same page for those who don't really know what H3 Africa is. Then I'll go on to setting up the research context and the output, some of the outputs of H3 Africa so far, and then discuss some of the technical GA4GH standards that are being used in H3 Africa, and give some few use cases on how we are all planning to use those. Next slide, please. So H3 Africa is a consortium that try to facilitate African-based research to try with the goal of improving the health of African populations. And it does that by really trying to invest in building capacity in human, and also building infrastructure where genomic research could be done. And as you can see on the image, we have the dots of African countries where that are currently involved in H3 Africa. And it also does that by really trying to build, a collaborative network on the African continent, as it said in Africa that if you want to go fast, go alone, but if you want to go far, go with others. So it's really important for us building these networks. And this network of Pan-African or African bioinformatics groups is led by the H3 Bionet, led by Nikki. Next slide, please. So ESTRA-BioNet is the Pan-African network, as I said, of African bioinformatics groups, with the aim to provide support in terms of bioinformatics and infrastructure to the East Africa consortium primarily, but it's doing that for the whole scientific community, primarily in Africa. And it has around 28 partners in 17 countries, with one of the nodes being in the US. And the support that it provides basically in bioinformatics and data analysis skills, providing infrastructure for data analysis, data transfer, and as I said, analysis, compute nodes, tools, workflows for doing analysis, but also providing a lot of support in data management and harmonization of East Africa data and phenotype data as well. Next slide, please. So through the year of existence of East Africa, there's been some really impressive outputs. We have around 170 million US dollar that has been invested. East Africa is around 30 countries in Africa that's now part of the consortium, and we have around 51 projects that are currently being run in East Africa. And as you can see, the numbers, there have been a lot of trainees, produced from the East Africa with a range of training that we provide in East Africa, but also in ESTRA-BioNet. And as you can see, there also there is also a lot of publications that have come from East Africa. Next slide, please. And East Africa research projects, focus on a number of phenotypes going from infectious diseases that are burden to the continent, including HIV, TB, and malaria, but also looking at some non-infectious diseases like cardiovascular diseases, stroke, kidney, going to mental health diseases, with a really vibrant, project that are focusing on monogenic diseases like sickle cell. So East Africa is producing a bunch of data and biospecimens with the phenotype data, including whole genome, exome, and targeted sequences being produced, phenotype data, genomic data, human and pathogen, with a number of projects also generating microbiome data. And the biospecimens go to East Africa biorepositories, and the data, the phenotype and genomic data go into public repositories such as the EGA. Next slide, please. And this is just to give you an idea of what East Africa is producing in terms of phenotype and genotype, phenotypic and genomic data. So we can see that so far we've recruited around over 100,000 participants, and we have projects that have genotyped more than 30,000 sample on the East Africa array that was designed and produced in around 2018. we generated a couple of whole genome sequences. We have some whole exome sequences, and also some targeted and RNA-seq data that have been produced so far. So this is really presenting a lot of opportunities in terms of the data that can be used to address some of the inequality that we've been observing and discussing for years when it comes to African or genomic research in Africa and in general of underrepresented populations in the world. Next slide, please. So there have been some output, as I said, in terms of publication, and I hope that we all had an opportunity to see the last one that was published in Nature. That was a consortium-wide project that looked at a bunch, a set of data sets, I think around 400 generated during the chip design, the East Africa chip design, and analyze this data set to try to get some insights from it. And this publication really gave us some impressive insights into the evolution, the migration, but also into some of the diseases that we looked at on the African continent. And this paper actually, pushed some of our investigators in Africa to try to put down some ambitious projects like the one trying to look at or to generate around 3 million genomes across Africa. But we also have on the right-hand side of your screen some of the new or ongoing projects looking at HLA repeats and some other diseases and mixture, trying to harmonize data sets, and some will be generating some new data sets. Next slide, please. So all of those are the data set that we're generating, and the analysis or the infrastructure that East Africa or East Bionet is putting together. It's really to help, as I said, to help us reach the goal of East Africa, which is to establish an African-based genomic research. And for that, really needs, let's say, building human capacity, but also setting up infrastructure. And one of the things that you need to do, we really want to do, as I said, is to be able to collaborate. And when you're talking about collaborating, we also looking at sharing the data among African researchers, but we with the whole community. So for that reason, we've been looking at solutions or technologies, standards that can help us do that. That's why we've been in GA4GH for some few years, trying to follow what's happening, which standards can be useful for East Africa, for the infrastructure that we're building. And yeah, I'm listing some of the products and where which one we're using. You'll see in red one, those are the ones that we adopting, and some where we contributing, and some that we think in future will be useful for the East Africa. And I'll come with some few use cases on how we're using or we're planning to use some of these standards. Next slide, please. So as the data were generated in East Africa, and we started thinking of sharing. So the context, the research context in East Africa is that the data is generated at the sites, at the research sites in a given country. And once the data is ready, gone through QC or filtering, cleaning, the data is sent to H3 Bionet that will prepare the data, store it for a short while before it is sent to EGA for long-term storage and archiving, as we don't have such facility yet on the African continent. And during that period that the data set is at H3 Bionet, we really try to map the data to different ontologies to make sure that the data is findable, accessible, interoperable, and reusable. So we map all our data sets to DO to make sure that all the restrictions and use acceptable use for the data is known. We're also trying to document all the consent form in East Africa with the DO codes so that our RBs and our investigators are aware of that. We also mapping our data set with GECO, which is an ontology produced by the Seneca project for describing codes data, also mapping to the African ethno-linguistic ontology to make sure that we describing properly the demographic data in the data set, the phenotype data that we have. Next slide, please. So as we do that, mapping consent info or the data set to DO, one of the challenges was the communication. How do we convince the PIs and get the consent forms needed to do this? So that was a challenge, but we were able to overcome that. And then there was some bit of confusion or challenges in some of the DO terms or codes or definitions. So working with the DO team was really useful as we were able to clear out some of this confusion or where the definition was not really clear. And one of the issues that we really wanted to tackle was the commercial use, because this is really a controversial issue due to the historical exploitation and misuse of African data. So that was clarified in DO. So far, we have around 20 data sets in East Africa that are mapped to DO, of which 8 are in EGA. Next slide, please. So in our catalog, all the data set that we mapped to DO are in our catalog, as you can see on this image. You're able to see as you're browsing the East Africa catalog, you can see all the DO codes for each of the data sets that you could be interested in. As well as on EGA, you're also able to see the DO codes for each of the data sets, the East Africa data set in EGA. Next, please. So now, just to give you an idea of an overview of the infrastructure that we're building and how we're trying to use the GA4GH standards. So this is the ecosystem that we're trying to build. We're starting from the participant recruitment at the site. Biospecimens are generated and sent to different biorepositories. The clinical data are generated, sent to INEA and stored in different clinical databases like REDCap and so on. And the genomic data set goes to the East Africa archive. and also in the African Genome Variation Database that we're building. And the metadata goes to the East Africa catalog. And now we're planning of setting up some beacon where we'll be able to serve some of this data. Next, please. And there you're seeing different standards, GA4GH standards that we're planning to use for these different services and tools that we busy deploying. And in the next slide, I'll quickly show you how we're planning to use this. For the East Africa archive, which is an internal short-term storage, where we receive data sets from projects before they go to EGA for long-term storage. We're storing all our data sets in using the Chrome format, the storage and analysis as well. And we're planning of using the GA4GH to encrypt all our data sets during storage, but also for transfer, because while we're keeping the data for short-term storage in our archive, the project PI can request data or the data to be transferred to an investigator. So encrypting that, we have to encrypt and decrypt the data set every time we do that. So GA4GH, the GA4GH could be really helpful for that. And we're also planning of using HTS-GET for data streaming in the archive. Next, please. And the second one is the African Genome Variation Database that we're building, which will be a user interface where we'll be able to share variation from East Africa or African data sets. And there we've been following the VR spec so that we could be used as a default way of saving variants. We're also trying to use planning to use the AI and passport for authentication authorization for different level of access to the database. And as we don't, there's no yet AI infrastructure on the African continent, we're planning of using Elixir for this matter while we're looking at building an AI for Africa. Next, please. The third one is the East Africa catalog I've mentioned, is a place where you can go see all the biospecimens available in East Africa from East Africa projects, but also data sets in EGA, and you can submit your request for access to the data sets, which our debug will look at and approve or disapprove your request. And there we're trying to we're planning of using Passport so that once your request is approved, the access, the data access can be streamlined with EGA because it's done manually now. So we have to communicate with EGA all the approved access to the data set sitting in EGA. Again, there we'll be using Elixir AI for now for authentication. Next, please. Another service or project that we're working on is the East Africa Imputation Service, which will be a place where investigators will go and impute the data set using the East Africa data. And there we're planning of using the GA4GH AI spec and Passport for managing how we give access to different reference panels and so on. So far, our current reference panel is around 4,400 samples with around 87 million variants from all the data sets listed there. Next, please. I think that's all that I wanted to discuss with you today. Is just an overview of all the services and the infrastructure that we're building, and I really think GA4GH will be helpful for us, getting to where we want to get with advancing genomic research on the African continent. I would like to thank the Old East Africa Consortium for all the hard work and the contribution made so far for advancing genomic research in the African continent, the H3 Bionet, all the funders, and especially the name listed there of the people that are part of our GA4GH activities so far. So thank you very much for attention and for listening.
That's great, Manana, and I'm so impressed at how much H3 Africa is taking GA4GH on board. I really hope you can stay for the social on spatial. I don't know how late it is in Cape Town, probably just as late as the UK. Let's just go for maybe one question here, just to keep us vaguely on time. I'll take the second one. What is the need to? Is there a need to translate geocodes and maybe other codes for patient consent across African languages? So basically, how much translation effort do you think the GA4GH infrastructure needs for it to be useful?
Yeah, I think that's a great question. And just speaking about South Africa, for instance, we have around 13 official languages, and you need really to translate or to have your consent form in language that your participants will understand. And as we look at the whole African continent, we're looking at around 500 languages. So I really think it will be useful for us if we want geocode to be really used on the African continent, to think of ways we can translate that into some high-level African languages, so that it will be really accessible to participants, to research participants.
That's great. Okay, thank you very much. And so our last speaker in this session is Lauren Fromont, who's at the European Genome Phenome Archive, EGA, at the CRG in Barcelona. She has a PhD in biomedical sciences from Montreal, and she coordinates now projects from the EU and is part of Elixir and GA4GH projects. Lauren, I think you're going to talk about the Beacon and enabling clinical data discovery with Beacon. Take it away, Lauren.
Thank you, Ellen, for the introduction. And yes, because we are on track about real-world implementation, I want to address the clinical world, that is hospitals and clinical research. And I will be talking about Beacon. So we can dive right in the next slide. So what I would like to start with is to give you a little bit of history about how we, from the Beacon, original Beacon concept, we elaborated a Beacon that is more clinical for the version 2. Then I will highlight some of clinically relevant features of that version, and then we'll go to the implementer side in clinical settings. And finally, I will talk a little bit about the Beacon network. So if we go to the next slide. So as you probably all know already, Beacon is a tool for data discovery. And originally, the Beacon protocol in its earlier versions allowed researchers to get information about the presence or absence of a given or specific genomic mutation in a set of data. So from patients of a given disease, for example, or from the population in general. So the metaphor we usually use is a game of Go Fish, because as a user, you would query the Beacon by asking, do you have this mutation at this specific chromosome in this position? And the Beacon will return yes or no, so the Boolean answer, and also it will tell you if it's not available. So perhaps we can go to the next slide. So from this concept, as you can see, was very simple, and it's part of this success. Then the Beacon team started thinking about how to improve the Beacon v2. So we started interviews with different stakeholders, and I wanted to bring your attention to a survey that was made back in 2018. And when asking partners what activity they were doing, 45% of diagnosis and 50% clinical research. So 60% already belong to the clinical world. And about the information about variants that they would like, well, all of their answers basically respond to clinical needs, so variant annotations and case information. So following this rather quantitative survey, then we conducted a set of more qualitative interviews with GA4GH driver projects, with foundations, and with different projects. So EGPRD, for example, H3 Africa, that we just had a wonderful talk about, Candig, etc. And the version 2 of the Beacon protocol that is going to be submitted early 2022, that is almost finalized. So I remember in Tommy's talk that they were impatient to see the version 2 out, and you won't be waiting much longer. This version 2 will include new features that are more clinically relevant. So for example, you will get access to more informative queries. For example, you'll be able to filter by gender or age. There's also going to be an option to be triggering the next step in the data access process. For example, by knowing who to contact or what are the data use conditions. Also an option to be jumping to another system where the data could be accessed. So for example, if the beacon is for an internal use of a hospital, then it could provide the ID of the EHR of the patient that have the mutation of interest. And then, of course, it would include annotations about variants. So among those would be the clinician's conclusion about the pathogenicity of a given mutation in a given individual, or its role of producing a given phenotype. And something I will come back to is information about cohorts. Now, if you could go to the next slide. Thank you. Now, if you have attended Jordi's talk yesterday, you're already familiar with the Beacon model. And if you haven't, well, I can summarize it in a few words. So basically, the Beacon model contains the data structure or schemas for the biological data. So what it does, it describes the set of concepts that are included in a Beacon version. What I want to stress here is how the Beacon model reflects the data cycle and all of the steps of the way are of interest for clinicians. So you will start with collections that encompass data sets and cohorts that are the remit of the experimenter. And then you would have individuals that include patients, for example, and also healthy controls. Biosamples are collected by clinicians themselves in a clinical setting. And analysis and runs would basically correspond to wet lab and dry lab measurements. And then you would have genomic variations, which is more bioinformatic information, if you will. Can go to the next slide. Then to go a little bit more into the cohorts example. I think it's a nice example when talking about clinical relevance, because if you can imagine a clinical researcher who wants to evaluate the efficacy of a chemotherapy on specific cancer types, depending on the age at which the cancer was diagnosed. So I completely made that up. So I'm not an oncology researcher. And then if you go to the next step, you see that this researcher would query for specific cohorts that can be defined as a set of individuals that would satisfy one or more inclusion criteria for a specific duration of time. And then if you go to the next step, you would get the beacon response. That would be, in a nutshell, a description about the cohort in a form of aggregated metadata, and it can include binary information about whether or not certain data types are available, number of individuals in each data type, and summary statistics. So if you go to the next slide, you will see that this response example is actually translated in different fields. So you would have the field metadata, inclusion or exclusion criteria, data usage that corresponds to the purpose of the original data collection of the specific cohort, statistics about number of individuals and so on, data types if it's genomics, phenotypic or clinical, and then collection events. I put in a link of a service registry of Seneca project, because this was really the project that motivated us to include cohorts into the beacon. And you can check it out using this link. I think the slides will be shared at some point. Now, when I've been working on Beacon for about a year, and usually when I talk to projects about Beacon, especially to clinical partners, maybe because of my clinical background, it's not so difficult to convey the idea that the Beacon will be extremely beneficial for in clinical settings, so for hospitals or for clinical research. People are generally very enthusiastic about Beacon. Where it gets more challenging is on the implementing side, and that's because depending on the setting you are in, you don't necessarily have the IT resources or the human resources to implement the beacon. And in addition, something I learned very early on is that the beacon as a global alliance product is a specification. It's a document, if you will. So it's very flexible. You can include as much or as little as you want after you have adopted the framework. And this versatility, this versatility is a good thing, but it can also be a bit frightening for implementers. So the Beacon team in the past year has been working very hard and more closely with clinical centers like hospitals, and this is a list of hospitals in Catalonia. And we have bioinformaticians and developers in our team having meetings with them in order to explain the concept and also helping them improving the existing solution in order to be able to build a beacon on top, and as well as understanding the code and being able to deploy themselves a beacon. And now if you go to next slide, another thing that we've been working on is improving the documentation, which is very important because it's the first thing you see, and interested parties might want to check out the different steps to implement a beacon. So there's general information on the website, and if you go next, you will find on the GitHub, on the GA4GH Beacon GitHub, READMEs that explain the Beacon framework and the Beacon model, which are especially relevant for implementers. And finally, we also have read the docs for the Beacon model, so the schemas that I described earlier. So if you go to the next one, you should be able to see an overview. And that describes in detail the fields that I was describing for cohorts as an example, but it does that for every single component of the model. Now, if we go to the next slide, so basically I hope that I managed to show you the value of adopting the second version of Beacon if you are in a clinical setting. Of course, every Beacon maintains a high level of security, and all clinical centers or all data centers remain the data controllers. So it's really only a discovery tool. What I wanted to stress here is that now, like, querying individual beacons is already an improvement to data discovery. But as a user, if I want to improve a specific aspect in personalized medicine, for example, or if I'm a researcher on rare diseases, then I need more data to conduct my project. So querying individual beacons might be a bit time consuming. This is why the ultimate step of beacons is actually to build a beacon network. And if we go to the next slide, you'll see that our project is to actually have an aggregator of beacons. So a given user would be sending a query to the network, and then the network would be contacting separate beacons and then presenting the response in an aggregated form. And I think with that, I am done. So my last slide is a thank you slide. Of course, the work I presented today is by no means mine. It's a work of the Beacon team. So we have a great community here. The champion is Jordi Ramla, who presented yesterday. I also threw in some links with the website, the GitHub, and the Beacon Global Alliance Approval Registry that is still under development, but we're planning to submit early 2022. If you have any further queries, please contact me. And I wanted to thank the organizers. Since I'm the last talk, I wanted to thank the organizers for a very smooth track, and as well as the Global Alliance administration for helping us through the submission process. Thank you.
Great, thank you, Lauren. And now let's see if we've got any questions on Slido. As they come up, Lauren, do you think the clinicians are more interested in your experience about starting from the phenotype side or the genotype side in this? You said that they would, they understand how they're going to use a beacon, but is it a phenotype or genotype or both?
Yeah, that's a good question. I think a lot of clinicians I've met in the context of projects. So their needs are really directed to a given project. So for example, if it's we have a project in oncology, sometimes we don't even have genomics data, but they would be interested in the phenotypic and clinical side. But for a project like Seneca, there clearly is an interest on the genomic side. So I would say it's a mix of both, really. And I think for the hospitals that we've been contacting in Catalonia, they're really aiming to use both informations, given that phenotypes, of course, are important for clinical discovery.
Okay. I think these two questions might be linked. When will Beacon version 2 be ready for general use? Is it ready now, or is it
So you mean for implementing, I guess?
Yeah,
I suppose.
yeah.
Yeah. So the Beacon version 2 is ready for implementation. What is happening right now is that we are still tweaking the last bits of the specification so that it's stable. So the interested parties who are right now implementing the beacons have agreed to provide feedback to the Beacon team in order to improve and stabilize the specification. Now, people who are interested in implementing a beacon, a stable version of beacon, I would say that we would wait until the official release that should be, I think, in March. I don't think we have the specific date yet. However, I would encourage anyone who's interested to contact us even before it's officially released, because we can start the process.
Okay, that's great. And then, do your beacons work with GA4GH passports? I think do they accept passports for federated Elixir AAI for access to certain layers?
I think so. My understanding is that beacons are normally agnostic to that in a way that it will maintain security whatever way you wish to maintain security. So if you're using GA4GH passport, then the beacon will use GA4GH passport. So it's compatible.
Okay, that's great. I think that's the end of the slides. Thank you very much, Lauren. And
thank you.
Now, Justina, shall we bring up the most important slide here, which is the social hour. So if you haven't met Spatial before, it's great. What you simply type in this URL, so https spatial.chat/s/GA4GH, and there will be a lovely kind of web room where you're a little bubble, and you can move between rooms and you talk to the people closest to your bubble. And so this will give us a way of meeting hopefully all the speakers and other people in the right time zone. I will certainly be there at 7:30 British time, so that's 6:30 UTC. If you're, I'll have a glass of wine, but if you're in a slightly later time zone, do come with a cup of coffee. So see you there. Thank you very much. Oh, and thank you also for all of your attention and being here. It's been lovely watching a bit of Slack and watching a bit of Twitter as people have been talking about this. I'm really looking forward to seeing you in the Spatial. Okay, great. Thank you very much indeed.